Dr. Karen, thank you very much, ladies and gentlemen. First of all, it's a great pleasure to be here in this beautiful place on behalf of the European Society of Cardiology. We in the European Society of Cardiology value your contribution to the society very much. So from this point of view, it's a great pleasure to be here and to join your very distinguished meeting here. So I was asked to talk on the syntax study, and probably you're all familiar with the syntax study because it's around now for almost 3 years. It was first presented at the European Congress of Cardiology in 2008. So we do have now already a 3 years follow-up, and I'd like to refer first to the publication New England Journal of Medicine that you're probably all aware of, and point out one word in this title, and that's this study is done to compare bypass surgery and percutaneous interventions in severe coronary artery disease. It's not the simple one or a double vessel disease, it's severe coronary artery disease. Now, this is the patient cohort. They started out with 1,800 patients, 897 randomized to CABG and 903 to PCI. And they have now a 3 years follow-up, and you see that the cohort is more or less complete. There's lost of follow-up only very few patients, so that is an excellent follow-up for such a large trial. Now, you're familiar with the 1 year results, which were the primary endpoint of the study, which is first the combined heart endpoints, death, myocardial infarction, and stroke, and there was no significant difference at 1 year between these 3 endpoints. There was an increased risk of stroke in patients that underwent bypass surgery as compared to PCI, and there was an increased risk of repeat revascularization in the PCI cohort, as this is very well known to us. Now, the primary endpoint was MACE, and MACE included repeat vascularization. Therefore, this study showed an advantage of bypass surgery based on this endpoint as compared to PCI. This was the selected endpoint, and this was a study to show non-inferiority, and it failed to show non-inferiority. In other words, with respect to this endpoint, including repeat revascularization, bypass surgery was better than PCI. Now, we do have now 3 years follow-up data, which are of course important, and again we start out here with the all-cause mortality up to 3 years. Mortality altogether was very low in this study, and there was at no time a significant difference in the total cohort with respect to mortality. So that's good news on one hand. Now, the next is cardiovascular accidents, strokes, so to speak. And you remember that there was an excess of stroke during the first year, but not during the following years. And so it's at 3 years, it's not statistically significant anymore, the difference in strokes. What about myocardial infarctions at 3 years? You see that there is a trend to an increased risk of myocardial infarctions in the group that underwent PCI with a Taxol stent, and this is highly significant difference now at 3 years. So and that's not good news for PCI, that there's a higher rate of myocardial infarctions. Now here's the all-cause mortality, the combined heart endpoints, strokes, and myocardial infarction over the 3 years follow-up, and there was no statistical significant difference. There was also at no time point any statistical significance between these heart endpoints. And repeat revascularization was highly significant difference, of course, as is seen during the first year, was borderline significant between year 1 and 2, and was also, but not significant between year 2 and 3. So the repeat revascularization that is linked to PCI really takes place during the first year. After that, these curves are more or less parallel. Now, the combined endpoint, which includes the 3 hard endpoints and repeat revascularization, is still highly significant, highly significant different at 3 years, p-value 0.001. But this leveled off, as you see here, this between year 2 and year 3, there's no significant difference between the two treatment modalities. Now, you're all familiar that within the syntax study, this syntax score was developed and used to classify the patients according to the severity of their coronary artery disease and the difficulty to perform PCI. Not the difficulty to perform CABG, but the difficulty to perform PCI. And this goes into the syntax score like calcification, thrombus, particularly total occlusion, then tortuosity, bifurcations, and these are the components of the syntax score. And there's one example here. A patient has a syntax score of 21, is still in a low risk group. It's triple vessel disease. As you see here, 1, 2, 3, 4 lesions. And this patient in the right coronary artery, left coronary artery LAD. And there's another patient with a very high score of 52. You see the right coronary artery is occluded, and here left main disease and also proximal LAD disease. So this patient's syntax score is very high. Of course, everyone would agree even before the time of the syntax score that this can be rather nicely done by PCI, whereas this is really seems inappropriate. Perform PCI, and this really seems to be a candidate for surgery, but these patients were included in the syntax trial. Now, if you want to learn more about the syntax score, you can go to the internet, and here on this free page you can download the calculator and calculate the syntax score yourself on your patients. Now, it's important to know now how is the event rates in these 3 different categories of the syntax score. There's one category from 0 to 21, and from 21, 52, and more than 52. And here's the lowest, or the lowest complication cohort, or the lowest severity cohort, syntax score up to 22. And this is MACE, which includes now repeat revascularization. And this, you see over here, this 3 years follow-up is really identical. There's no difference between surgery and stenting with the Taxo stent. Now, the intermediate cohort, syntax score 23 to 32, you see that there already develops a significant difference, and that's statistically significant here at 3 years. So the intermediate severity of coronary artery disease is linked to better outcome of the surgery, which includes, again, however, repeat revascularization. And this is syntax score over 33, and you see here that there's a very clear difference between the two treatment modalities, that from the beginning on, surgery is doing much better than the stenting. So, but this is, to my point of view, not new news. This has been known more or less for a long time. We all knew investigators performing PCI that the more severe disease is, the better surgery is. And like here from the Duke registry, we know this from a very long time, that this is based on 18,000 patients that and this is shown here is the survival benefit with revascularization at all versus conservative. And you see here, the higher the severity is of coronary artery disease, the more survival benefit you have. And if you compare now surgery with PCI, it becomes also very clear, and the same message from the syntax trial. In the high severity people, you gain more life by surgery as compared to PCI. So this is should be more or less familiar to us. Now, the question now is the data of the syntax score really representative what we are doing in daily life, and how can we apply it to daily life, or what is really the lesson for syntax for us. And let's go first a little bit more in detail on the background how PCI was performed and how CABG was performed in the syntax trial. And you see here the average length of the stents, and you see with 86 millimeter stents, this is really long stents are used. The total length is really long as compared to many other studies, as compared to the ART study. So my point of view, they were a little bit overdoing the stenting. And particularly if you look now at the number of stents, 48% of the patients received more than 5 or at least 5 stents. And the average stent per patient was 4.6, at least in my daily experience. That is rather rare. And if you see here that some patients received up to 14 stents, that's really not routine practice. I think also in most of your places, that's not routine practice. And there's this very close link to the repeat intervention or to MACE rates and to the number of stents implanted. You see here, this is the stents implanted in the Syntax trial. We are in this area. This increases the MACE rate. If you work on the lower, the real world average here, it's about in this area, then the MACE rate is much lower. So the number of stents is linked to MACE rates, and the stents were very high as compared to real world in the Syntax study. Another point is that we have better stents today. The Tercile stent probably is not the best drug-eluting stent we have around. And there are head-to-head trials with later generation stents like the Science V stent. This compared in the Spirit 3 trial, and you see here that's a clear advantage in target vessel failure and also in heart endpoints of the better stents or more recent stents as compared to the Tercile stent. So the outcome of the study may have been slightly better, not completely different, but slightly better by use of more recent drug-eluting stents. On the other hand, the surgeons did very well. Congratulations to the surgeons. You see here the one-year mortality in the Syntax trial, which was very low in the surgical arm compared to other trials performed around the same time, including triple vessel disease and main stem lesion. You see that mortality here usually trends to be much higher. So they had excellent surgeons in the Syntax trial, and you have to compare and see how in your own institution the quality of surgery is. Another difference, and this now goes to the address of the surgeons, is that the surgical patients were not treated optimal post-operatively. You see here, not only with aspirin that patients after surgery receive less aspirin, but other drugs which really are linked to outcome, like statins, like ACE inhibitors, like ARBs, angiotensin receptor antagonists, are really significantly less used in the surgical cohort. For those surgeons, there's still room to improve the outcome. Now, in summary, the take-home message is that reintervention with PCI is still a problem. Main stem is no mystery, and it's one of the major outcomes. You may perform PCI main stem lesions. It's not really such a high risk. The PCI technique maybe was not representative really in the Syntax trial, and has improved. The medical management, particularly in the CABG arm, is still suboptimal. And still the best choice is in individual decision making, but based on the Syntax results and based on guidelines. And this what I like to discuss with you now on the following, because the Syntax had major impact on our new ESC guidelines that were published last year. The guidelines are myocardial revascularizations. And these guidelines are in one respect unique, because they are not devices orientated or technique orientated, they are patient orientated. They are orientated to what at the very end has a best benefit to the patient. And therefore the patient now much more time is concentrated on here how to get informed consent for the patient. So the patient has to get involved much more in the decision process, particularly in the decision between PCI and surgery. And for this, the heart team now is established, as it has been used in the Syntax trial, and it's now in the guideline. It's strongly recommended that you establish at your institution a heart team that discusses all patients with multivessel disease. Not every patient that undergoes PCI, but all patients with multivessel disease and main stem should be discussed or enter somehow the heart team at your institution. And now the guideline differentiates between revascularization for prognosis, which is what we all know, left main disease, proximal LAD disease, triple vessel disease, and it's very important that you have to prove that there is a large area of ischemia, more than 10% of the left ventricular mass, because this is only linked to improvement in outcome. And for this, it is advocated that you use dynamic measurements for ischemia, like fractional flow reserve, which has not been done in the syntax trial, but it's strongly recommended to do by the guidelines to use this to really prove that the lesion you are treating is hemodynamically significant, because only by this you'll be able to improve the prognosis. And there are some indications left for improving symptoms, but this mainly to patients that really are unresponsive to optical medical treatment, or in other words, patients that respond well to treatment, to optical medical treatment, have no symptoms, they should not undergo revascularization. So that's a different point of view. We're doing no cosmetics on the coronary artery. We have to have a clear indication, improving the prognosis or improving symptoms. And this is maybe one of the most important tables from these guidelines, which but opens, on the other hand, also some questions. Of course, there's no debate here, single and double vessel disease, that this is very well done by PCI, but in some exceptions also by surgery. It's more complicated here in these kind of patients that have triple vessel disease, involvement of the main stem or not, and you see that the syntax score here is used for these recommendations. And you may see that there are a lot of green lights here for surgery with 1A high recommendation, and PCI is not doing so well. It's having here red lights or yellow lights, so you may do it, but surgery seems to be the better one. However, there are some open questions related to this, because as references for 1A here, these are not head-to-head trials except for the syntax score, but this is based on old studies, CABG versus conservative trial. So in my personal belief, this is maybe ranked a little bit too high. Here, the 1A is achieved because you compare surgery with medical management, and one study only that surgical compares with PCI. But there are no new studies on the horizon that may clarify this a little bit more, and maybe turn the yellow lights of the PCI in the near future also into a green light, at least for some special indications. What we don't want at the very end is that we debate too much in front of the patient. We should be very clear about the decision we make or we suggest to the patient, and therefore the heart team, this is my last message for you, the heart team is very important. It's a new institution that should facilitate communication between cardiac surgeons and cardiologists, and I think this is a very important message, not only from syntax, but also from the guidelines. Thank you very much for your attention.